in the chat box, if you're able to see it on your screens, I put down a brief introduction of who I am as an example. Just we're hoping everybody will put your full name, your agency affiliation, your role within the agency in the chat box so that we have a proper attendance. We know what agencies are represented. And if you have others sitting with you that may not be represented as an attendee, please put their names in the chat box as well. And we're going to get started in just a sec. All right, Chuck, Don, you guys ready?
Yep, I'm here.
Okay, great. So good evening, everybody. Good evening, Nassau County. Just again, for brief housekeeping, we're going to start with, please put all your questions into the chat for discussion. So into the same chat that you're introducing yourself at. This will help create ideas and perhaps allow other people to see what you're thinking in case they missed a question. The second thing is we're going to ask that uh, when you put your question into the chat box, you can also raise your hand to be called on. We ask that you please keep your microphones muted at all times because there are going to be a lot of people on this call, and we don't want to have background noise impairing the ability for others to participate and learn from this. So the purpose of this meeting is to put basically to again introduce ourselves as leaders for you, volunteer leaders of EMS in the Nassau region, and to serve as a follow-up for regional EMS agency, EMS agency and medical director leadership to those responsible for providing the out-of-hospital care for EMS services in Nassau County. As we introduce ourselves, you're going to see other people on the speaker list. Those are folks from General Devices. They're going to be talking to us about our new up-and-coming communications program or process called eBridge, which I'll let them talk to. And when we get to that point, we'll introduce them. So first, good evening. I'm going to introduce myself. My name is David Kugler. Happy New Year to everybody. I'm an emergency physician and EMS physician. I've been elected by my colleagues on the REMAC to serve as the chair of the REMAC. And in that role, at the discretion of the REMSCO, I also serve as the Nassau County Regional EMS Medical Director. I'm dual board certified in emergency medicine and EMS. I've also been a volunteer in the Nassau and Suffolk EMS systems for over 38 years as both a paramedic and a firefighter. In addition, I work at the Northwell Health Emergency Department at both Plainview and Syosset hospitals, as well as for their Northwell Health EMS division. So with that, Chuck, would you like to share a little bit about yourself?
Yeah, sure. Thank you, Dr. Kugler. As Dr. Kugler said, I'd like to thank all of our attendees and stuff tonight, all the agency managers, medical directors, for taking time out this Saturday night to once again take in this presentation. After the presentation, there will be some information given out regarding the current state of EMS as well as the regional council here. As Dr. Kugler said, most of you know me. My name is Charles Mackey. I'm a nationally registered paramedic and currently the elected chairman of the regional EMS council. I was a former police medic with the Nassau County Police Department, and I am currently an instructor with both the Fire Police EMS Academy and the Nassau County EMS Academy in Old Bethpage. So once again, I want to thank everybody for being here. And once again, our goal here is to once again get dispel any rumors that are out there. Once again, give you an update on where the system stands, what we're currently doing, how the program agency is working, as we're working towards reestablishing the program agency, and also to answer your questions on how we can better improve not only for the agencies but for the residents that we serve here in Nassau County.
Oh, that was great, Chuck. Thank you. And Don, you're on, and you're up.
Yeah. Good evening.
You muted yourself, Don, and now you're off the screen.
Yeah, that's all I got. Keep it short.
Oh, we didn't hear you.
Us, away we go.
Okay, Don Hudson, the Regional EMS Coordinator. Thank you very much. Do we have any other Nassau County REMAC REMSCO leadership on the call that would like to introduce themselves?
Hi, it's David Caldwell. I'm the Vice Chairman of REMSCO.
Sorry about that, Dave. I didn't see you there. Thank you. So Dave Caldor is also a paramedic. He's the vice chair and also a Nassau County EMS expert. So thank you. So moving on, we have two colleagues with us from General Devices eBridge. If you guys want to come on, we'll start your presentation. This way you could get it going. Mike Pisano and Randall Hawkins from different parts of our country. They're going to introduce themselves and give us a presentation. So I'm going to go muted and off camera.
Well, good evening, everyone. My name is Randall Hawkins. I am the National Sales Director for General Devices. I've been with General Devices for 13 years now. As you can tell, I'm definitely not from your part of the country. Born and raised in the state of North Carolina. I've also been a firefighter paramedic in the state of North Carolina my entire adult life. Of course, I've been with General Devices for 13 years.
Excellent. My name is Michael Pisano. I'm the Northeast Regional Manager for General Devices. I just started back in June. Previously, I worked as a firefighter paramedic in Pennsylvania, about 40 minutes outside of Philadelphia, serving as an ALS coordinator for a combination fire department. And I've been in public safety and emergency services for a little over a decade now. I want to thank you all for your time and thank you for allowing us to present some updates with eBridge and in relation to how it is with Nassau County. So I have my screen shared here right now. I promise you I'm not going to bore you all to death with PowerPoint, and your time is very valuable to both Randall and I this evening. So after the presentation, we will definitely have some time for some questions, and we value any input that you guys have as well. So we already gave some introductions. Here is kind of just a little more of a blur, but we definitely covered all of that. So speaking about General Devices, so we've been around for 40 plus years in business. We're a communications and a healthcare communications company, and our core purpose is to improve the health and well-being of the public at large through this idea of responsive innovation. So what responsive innovation is we recognize not only as a company, but our leadership that the healthcare system is ever changing, and we like to respond to that and innovative in different ways. I know that both of our solutions, and especially the eBridge solution that we're going to speak on this evening, definitely the configurability and the innovative ideas through that solution speak wonders. So where did all this come about? There was a policy and there's a working living document that the Nassau County REMAC and REMSCO have approved for communications with your facilities. So this is kind of just like a small little blur of that. There's the link down here as well. And I got this right from the website of Nassau County REMAC. And this kind of just speaks on that. This is how we built out the application. So we built out different buttons and things like that that we're going to dive into, pretty much based on this living document. So in saying that as a living document, Dr. Kugler and everybody recognizes, especially us at GD, that there could be some challenges, some changes to overcome. And that just speaks on our configurability that we're more than happy to work through that with you guys as our partners and team members. So I'd like to start with speaking on security of the application. So eBridge is completely HIPAA secure. So all the patient and protected information related to patients is extremely secure sent through the application. On top of HIPAA security, it's also fully encrypted. So all the messages, video conferences, everything like that is fully encrypted within the application. There's different layers of security though that we like to break down. So the first one is mobile security. So any alert, any picture, any video, anything that's taken in the application, it does not save on that housing device. So that is just enhancing part of that security. Another feature we like to touch on is the user restrictions. So an example I give here is if we're sending an alert and let's just say it's a burn patient and I'm working medic 1 and Randall's working medic 2, and I want him to see a picture of this burn patient I just sent to one of your facilities, obviously that's not HIPAA secure. So we can input different restrictions on who and whom may be receiving these notifications and alerts. The compatibility with eBridge, it works on all Android, iOS, and Windows devices. So there's no really additional hardware that really needs to be purchased, whether it be running on an individual provider's phone or a computer in the back of the rig that you're already doing some patient charting on. That's what eBridge can work on all around. And then here's just a screenshot of what your configuration looks like. And we're still currently building out the different buttons and everything for your configuration. But again, this is all related on the policy that was released with the different buttons and alerts that we have to build out for you guys. So it's really exciting. So diving a little bit deeper into eBridge with some features, benefits, and how it can really value you guys and save you guys time so you can ultimately get back to patient care, bettering the patient experience in Nassau County, is the simple secure photos. So if you're going to take a photo of an accident scene to send as a trauma alert, if you're going to take a photo of a 12-lead EKG and have the patient's driver's license on top of that, these are all just different examples of what different pictures you can send through the application and how it can enhance the care of the patient, ultimately better preparing the emergency department for your arrival. We have the ability to store and forward video clips. So the big example I like to give here is our patients exhibiting signs and symptoms of stroke, but ultimately on top of that, our patients who are experiencing a TIA. So I know from my past experience, if I'm entering someone's house and they're experiencing facial droops, slurred speech, all the signs and symptoms of a stroke that you all know, I would like to capture that so it can ultimately be saved with that patient and then eventually attached to their patient record. So if I'm able to record a video recording of my entire stroke exam, store that, and then when I'm ready to send the rest of my notification, forward this off to the hospital, that's one of the values there. Once arriving at the hospital, if the patient's symptoms have subsided and they are experiencing that TIA, we still have a time-marked activity of when they were experiencing those symptoms to better their care. We also have live video streaming. So what comes with this is a lot of your high-risk refusal patients. So sometimes it's difficult for us in the field to talk somebody into going to the hospital, advocating for them, especially if they really need to see a physician and really go to that. So we have this idea of bringing now the emergency department to the patient instead of historically we're bringing the patient to the emergency department. So there's a lot of value in the patients being able to see a physician on the other end of the phone and speak with them in live time. The physician can potentially do an exam on that patient, and they can, ultimately, hopefully, talk them into making an appropriate decision, whether it be go to the hospital or refuse and stay at home. All of these messages and consults are fully encrypted. This is recorded, so it's time-stamped and recorded and saved within the device, and there's no additional special equipment that's needed because this is obviously running on iOS, Windows, and Android devices. And this is probably my favorite feature of eBridge is this idea of live GPS tracking. So it's pretty much kind of like Uber. Every 17 seconds, the tracking is going to update. So once an alert is sent from your device, it's going to appear on a screen like this in one of the emergency departments. And then once you get closer and closer to that emergency department, obviously your ETA is going to shrink and get shorter. And then also on the map screen, they're going to see exactly where you guys are. If you guys look around here where the hospital is, there is a blue geofence around there. So once the EMS unit and once you do arrive at the facility, there can be an audible and a visual alert. Right when that happens and you arrive within that geofence, the GPS tracking is turned off and is no longer recording your locations. And then there's this idea of two-way communication. So obviously, with us working in the field, we like to be partners with our different healthcare facilities. So there's the opportunity for these healthcare facilities to now communicate with you guys directly through this application. So whether it be a diversion status, whether it be an internal disaster going on, a CAT scan machine down, the configurability of our buttons is we can make any button possible. The example I like to give to a lot of our hospital demonstrations is we can put a Starbucks button in there. So if the ER nurse, manager, whoever has their favorite EMS crew and they want to send them a message to pick up their favorite Starbucks order, they can simply hit that, send that message off to you guys. You can acknowledge it, as I'll show you in a little bit. And then there'll be live GPS tracking directly to you guys. Hopefully you can get that Starbucks order over to them pretty quickly so it still stays warm. So I really want to walk you guys through an example of what a case could look like. So you see on my screen here, the right-hand side is what a demonstration of what a EMS device could look like. So we're going to draw our attention up here to this general medical button. So we're simply going to click that. And the ease of this, let's just say we're an EMS agency, and we're coming in with a low acuity patient. How about it's going to be a 67-year-old female, and we can scroll down and we'll say that patient's having abdominal pain. So we'll simply come down to the bottom notify button here that's green and click that, confirm that we're wishing to notify the hospital, and that's it.
Mike, the only thing showing is your PowerPoint.
Oops, sorry about that. Are you able to see that screen now?
Nope.
No.
May have to back out and share your whole desktop.
Yep. Give me 1 second. Sorry about that, guys. There we go. Okay. So we should see this. Now, can you see the screen?
Yes, thank you.
Awesome. So let me go back to live GPS tracking because we spoke on that. Again, speaking a little bit more on the live GPS tracking, this is my favorite feature with eBridge. I really like to hone in on this, but it looks just like Uber. So once the unit gets closer and closer, once they arrive at the facility, they'll receive an audible and a visual alert, just like you guys saw right there. So going back to the case, let's start this over now. And we're going to pull up what my iPad looks like here. So here we have a demonstration of what your configuration is most likely going to look like. So if you draw your attention up here to the top of the screen where it says General Medical, we're going to click on that again. And the ease of the simply inputting the data, we'll do again a low priority. We'll keep it as that 67-year-old female, and we'll scroll down here and we'll hit that the patient's having abdominal pain. We're going to hit this bottom green notify button. We're going to confirm the notification. And just like that, you guys are done. This screen right here is what the hospital is receiving. So the hospital is going to be able to see an audible and a visual alert. And right down here, you see this blinking acknowledgement button. So this is that value of that two-way communication where the hospital is able to communicate back with you. So simply by the hospital clicking this acknowledge EMS button, you're going to see on this PC, or I'm sorry, on this tablet, that there's an audible and a visual alert here, and it said that the message was acknowledged. So there's a lot of information in here, but we just started out this case, right? So we just found out that we have a 67-year-old female, that patient's having abdominal pain, and that's pretty much all that we have right now. So let's say we go and we put our patient on the monitor and we want to attach a set of vital signs for our patient. So we can simply click our photo option, take a picture of a LifePak monitor or any of the monitors, and then attach that photo right there. So you can see on the hospital side, on the left-hand side here, that the photo is pulled up and they're able to see exactly what that is. This picture can be a picture of a 12-lead EKG that's printed off with a driver's license to hopefully eventually pre-register the patient, anything like that. So pull the tablet back up here. And let's say, the ER acknowledged this, and now they want to tell you where to go. So simply they can type in, let's say we're going to go to room 10 with this patient. And send that message back to you, give you a room assignment. You see that the case was updated and there's a new chat in there. So simply clicking the view button opens that up and there's a new chat so that you guys can now know, okay, well, we're going to go to room 10 with this patient. So while we're transporting the patient, we're obviously involved in patient care. Having this case pulled up, though, is definitely a value and a benefit. Walking through, starting from the top, we definitely have a lot of resources that are potentially needed for our different patient populations. If we need a resuscitation team, if we need security needed, potentially a translator, everything like that. And these are all different examples because this application is extremely configurable. So whatever you guys would like to see in here, especially working with REMSCO and BREMAC, we can make that happen. Scrolling down more, you were able to record a video of this like I spoke about. You can record an audio clip of a report that you would like to give to the hospital, or even what we see across the country, a lot of different facilities, the EMS stakeholders are doing is they're clicking on this narrative button and they're clicking the voice to text feature and then simply having it transcribe all the different text into a report right here. Under chief complaint, there's obviously a list that you guys can choose from with simple push buttons. If it doesn't fall on that list, again, another option is just can type that in. You can input vital signs or just do simply what I just did and just took a picture of the monitor and it comes over and it's very clear as well. Your different treatments that you're providing, you're able to have this dialogue back and forth with the hospital through this group chat function right here. And then if you want to go to room 10, they can ask simple questions, things like that. As you see all the way at the bottom here, everything is timestamped, when the notification was sent, when it was acknowledged, everything like that. So let's just say though, now this patient, unfortunately, the status changes and they go into cardiac arrest or something like that. Simply by clicking this add event at the bottom, you can easily click patient went into cardiac arrest. And what that is doing is notifying the hospital with a timestamp, the situation has changed. So again, there's communication back and forth. There's audible and visual alerts back and forth. Everything like that, extremely beneficial for the patient. Just going to turn my camera off real quick and show you guys another feature of eBridge is this idea to call EMS back. So the hospital, again, with having more conversation and more communication with you guys, they're able to call you back in an audio or a video conversation. So simply they will click this button. I'm just going to mute my tablet, and then right here you can see it goes through. So that video consult was recorded, and it's also added onto this case. So you can see all the way at the bottom that there was an attempt to consult with EMS. The consult went through and was there. All right here, just different use cases that we are familiar with and that we use often. But again, with the configurability of eBridge and the communication aspects of this, it's definitely a very good application. We make this application, we build this from the ground up for you guys so that the user experience and the ease for you guys is definitely a lot better. So I'd love to open up the floor to any questions if you guys have anything for us.
Bob Bristol. Get on mute.
Looks like Rob's raising his hand.
Hi, can you hear me?
Yes.
So I love the direction where this is going. I just have concern of the duplication of data entry with our already electronic medical records with, vital signs, et cetera, et cetera. And I'm sure that this will get outlined in, regional policy, but does eBridge work or will it have the ability to connect to our EMR vendors, whether it's through image trends through the state or whatnot? Will that be captured or be able to be attached to our official patient record?
No, excellent question, Rob. So right now it cannot, as it stands today. We at GD have partnered with a third-party integration company. So our idea is by Q2 of 2023, so this year, we will have integration capabilities. However, right now, I don't know exactly what that looks like. So I don't want to dive too deep into that, but it is very exciting because that's been an ask from our team and our company for a while to have this integration capability.
I'd like to add on top of that too, Mike, that one of the things that I think Dr. Cooper and everyone wants this program and this project to do is really just improve the way we're communicating back and forth. So we don't really want people to see this necessarily as a documentation tool, just more so as a communication tool. So think of it that instead of having to spend 3 minutes talking and telling the person what you want to say, with a couple of clicks, you can show them and send them what you want to say. So in doing that, there will be some good documentation captured that will be available for you guys to go back and run reports on, to go back and view later, to listen to the calls, look at the attachments, even download and export those. So that information could be dragged and dropped into any other format currently. And as Mike said, hopefully in Q2 of this year with our third-party integration, we will be able to interact with the PCRs and EMRs.
Great, thank you.
Thank you, Rob.
And it's Don. Let me jump in. So Rob, like anything else, we'll start slow initially just to supplement, now. Supplement. This will give, as they said, GPS awareness to the hospital of our actual ET. Just a cursory triage tag color. So that's a lot of the heads, and that future is all unwritten. This is a documented. That it's in. Oh, and yeah.
Yeah, Mike?
So this is David. I apologize. Sometimes when we work from home, we have bandwidth issues. So I'm not sure if everybody heard what Don said, but basically what he's saying is this is a growing, living thing that we're going to evolve with and develop our policies and procedures as we get better with it, as we get more accustomed to it, as the eBridge program grows and develops. It is to facilitate communication. So one of the things that we saw today, Mike shared with us that as a provider, all you have to do is click the voice to text button. And when you're giving your presentation to the hospital, which will also be shared with medical control as regionally required, you just give your audio presentation into voice to text, hit send, and the hospital will get it and medical control will get it. And that should be enough. That will initiate the conversation. That will start the notification process. So it's a couple of button clicks and a voice to text, and you should go. It shouldn't be too difficult. Again, like anything we use, any new tool, there's going to be a learning curve. And by next year at this time, I'm sure everybody's going to be up and running and operationally smooth with this. You also have to remember our hospital partners are also learning how to use this. They're just coming on board with it. There's a lot of in-service going on with the hospital side. They're just purchasing the tool. They have to train the nurses. They have to train their teams and whatever services that they're going to use as they expand out on the hospital side. Because this is such a robust communications tool, it can be used throughout the hospital to notify the STEMI team, the trauma team, the stroke team, in addition to the ER resources that you may require when you're coming into the hospital. So one thing that I think wasn't mentioned and the question wasn't asked, I think is very important. The hospitals are not usurping medical control. Medical control is still going to be given and done by the Nassau County Regional Medical Control. And that's currently at Nassau County Medical Center, and it's manned by the EAB staff. So we're not changing that. So there's actually a selection on this tool, the user interface that says medical control. You can select that, and then at the same time also select the hospital destination. So the hospital will get notified of what you're communicating with medical control about, and that will serve as your notification. I think that it's pretty easy, and in that you can start having a conversation, and rather than have this game of telephone where part of the information gets relayed to the hospital and not all of it, and then you get to the hospital and you're upset that the hospital isn't ready for you because they only got part of the information or the situation changed, this is going to keep the dynamic communication open, and it's going to improve patient care. So hopefully, at one of the other things that we talk about is how much time we spend on the wall, right? That'll be a topic coming up in a bit. If the hospital doesn't know you're coming, or the hospital doesn't have the resources available for you, then you may wait a little bit longer. So this is going to help you. It's going to help them know that you're coming, so they could say, okay, well, that kind of patient could go to triage. That kind of patient can go to bed 10, like Mike put in his example, or bring that patient right to the resus bay. Uh, we, I think this tool is fantastic. Right now, we don't have that ability. If the hospital asks the medical control the question, the answer is usually, I don't know, and they'll say, we'll try to get the crew back on the phone, but sometimes they can't because you guys have gotten busy doing your patient care, and you're not listening up for the medical control radio for your unit to be called. So it's just going to move us forward, and improve patient care for everybody, improve throughput, improve quality of communication. I think this is a great tool. Just one other thing for the region to understand is that this is not something that the REMAC and the REMSCO picked lightly. We looked at all the different pre-hospital communication tools. We looked at triage, we looked at eBridge, we looked at a couple of other tools. And after vetting all of them, the eBridge tool was the one that was selected. It was not only selected by us, but our partners in New York City and Suffolk County. So on either side of our region are using this tool. So eventually this will allow for collaboration with facilities not within Nassau County. So there's even bigger picture, ways to look at this if we keep zooming out. Does anybody have any questions about what I've shared with you regarding eBridge, or any questions for Mike or Randall? Did anybody hear me?
Yeah, Doc,
Yes.
it's Chuck.
Yeah, because
Okay.
it's loud and clear, Doc.
Okay, so we got a question. Mike Capel. I don't know how to unmute.
Yeah, hi.
people.
Good evening. This is all being funded by NASA, or is this going to have any funding impact on fire departments or EMS agencies?
So I'm glad you asked that question. Part of the requirement, so that there was no cost outlay to the volunteer fire departments, the EMS agencies, was that the hospitals were going to shoulder the burden for the expense of this system. Every hospital, the cost of the system was divided among all 13 hospitals in Nassau County. And that's part of the other side of this conversation that I've been dealing with for the better part of a couple of years, is getting the hospitals to kick in and support regional EMS in Nassau County. And guess what? They see it as an important tool, and they are actually supporting the cost for this. So each hospital is paying a lot of money to General Devices so that the volunteers can have free access to this service. So no expense to your fire department, no expense to your EMS agency, no expense to the provider. The only thing you have to do is download an app.
Awesome. One other question, if I can.
Sure.
So when we have the volunteer fire departments, EMS agencies that are cooperating and get this eBridge program, what about our city partners or private agencies or other volunteers that are not part of the system? They're not going to have this in there, so you could end up having 5 patients in the ER at once, even without any notification.
First of all, Suffolk County is also using this tool. So the hospitals that have the ability to receive the Suffolk County notifications will. Remember, we're doing baby steps. We're just trying this out and seeing what our heartaches are. And yes, of course, if as we need to expand regionally, we will. I think that right now let's do something small, like, hey, let's do the Nassau units first and the Nassau hospitals, and then we can expand out. But you brought up a great point. We do need to be able to share data and share information regionally, because if something happens in Suffolk County or in New York City that impacts Nassau County, we need to know about it, and probably everybody should know about it. Right now, we do have the hospital status board. I'm not sure if you're all familiar with it. We'll address it again in our conversation tonight. But that's one way we're communicating to you the status, the operational status of our hospitals in our region. So I don't want to talk around your question, but I think that we will be doing what you're doing, but we also need to get buy-in. Nassau County can't tell New York City what to do. Nassau County can't tell Suffolk County what to do. We can ask. Does that help answer your question?
Gotcha. Absolutely. New York City doesn't tell New York City what to do. That's a whole nother problem. And this is going to be kept in triage, and even if the nurses don't answer it, we'll just, continue in anyway, correct? Just as we've done in the past.
Yes, I could tell you that it's going to be very annoying, especially if you have a high priority patient. If it's not acknowledged, it's just going to keep alarming on their device. Every hospital is going to set up how they want to configure the receipt of the information differently. And it's usually going to be the ambulance triage nurse, the charge nurse. There's probably going to be a station on the doctor's desk that will all demonstrate an alert of a patient coming. I can't tell you how every hospital is going to set it up because that's not my business to tell a hospital what to do. But if they don't acknowledge it, it's just going to be getting louder and louder and be very annoying until they do acknowledge it. That's one. Two, if we're getting reports that hospitals aren't acknowledging in a timely fashion, we'll see that because we're going to have a data tracking tool that we'll be able to see all the communications, see who's acknowledging them, see when they're getting acknowledged, because every individual that uses this resource has to log in to receive it. So people are concerned, well, what if I'm not on duty? I don't want to get messages. Well, then log out. You won't get any messages. It's very simple. And so the same thing with a hospital. When they come on duty, they have to log in, just like when you go on duty with your EMS agency. You log in, and this way, when you get a run, you're already logged in. You're just ready to go.
Hey, Doc.
Great. Thank you very much. Thanks.
Yeah. Hey, Chuck.
Hey,
Oh,
how you
sure.
doing? Yeah, just to reiterate, as Dr. Kugler has elaborated on, this is a new system. It's going to take a little while for us to get it up and running and stuff sometime this year. It's not, as we've said at all the meetings and stuff, this is not to supplant medical control in any way, shape, or form. This is an enhancement of our communications platform that we'll be able to get the information not only to medical control, but to the hospitals and be able to update in real time, whether it be BLS or ALS, to get that information, just like we're doing with getting the information out on our redirection and diversion policies and stuff. So, once again, medical control will still handle all ALS communications regarding any thing out in the field that needs medications wise. They will still be involved in this process. This is just a enhancement of our communications policies and to make it easier for the providers to be able to get that information to the hospitals in a timely fashion.
So two things. First, I want to just acknowledge Mr. Blocker, who's been patiently waiting, and then we'll answer that other question that just came up.
Hi, thank you. Good evening. So just to understand the workflow, so we're still contacting medical control on the radio, and then and if we notify through the app, then Medcom is sending it through eBridge to the hospital that we're directing to, or when we notify, does that directly get sent to the hospital?
So it's a dual notification on the eBridge app. There's no longer a need to use the 700, 800 radio. That will be there as a fail-safe because we always know as an emergency provider, we always need to have backups. Just like a copper wire phone is available in every emergency room. We need to have a dual method of transmission of emergency communications. So your communication, when you make your notification, you're going to select the hospital. It's automatically in the back end. You're not even going to see this. Medical control is going to be notified. If you're selecting medical control, you have to pick a hospital because the hospital is going to get notified of the transport, and then medical control communication will ensue. When they pick up the phone or they pick up the eBridge device and acknowledge your request, you'll be able to communicate with them either by voice or by video or by text and engage in medical control for orders. So hopefully
Great. And
the radio communications will be only as a backup.
all right, one other follow-up question, if you don't mind. So then both the hospital or medical control could then respond back to us with a question because they're all looped in on the same
Correct.
piece of information.
Correct. And medical control can ask you. So, say for example, you forgot to search the hospital status board, and you selected my hospital, Plainview Hospital, but a plane just flew into the building. You didn't know that because you were half asleep, and you decided to go en route to the hospital. You selected Plainview Hospital, medical control, and medical control will get back to you and say, "I'm sorry, Plainview Hospital's closed. You need to go someplace else, like maybe New York City."
Okay, and then are the logins specific to each provider, or are the logins you log in as your agency?
So because we need to have good quality control, we need to know who's providing the presentations. We need to know who's acknowledging. Everybody's going to have their own user ID. On the hospital side, the hospitals will control their logins. On the EMS side, the region is going to control the logins. And now, so say for example, you're John or Jane Smith, and you join your volunteer fire department to do EMS, and then you get disgruntled, or you get a job, or you go to college and you leave. You don't need to have access anymore. As a matter of fact, you shouldn't have access. So we will remove your access. We don't leave the control of the access up to the agency. It's going to be up to the region. And that's just for regional quality and, for HIPAA protection and all those other things.
Great. Thank you very much.
Sure. Don, you got to get closer to your mic, bud.
How's that? Any better?
No.
How about now?
Much better.
All right, sorry about that. I don't want to hold up the GD devices, guys. Randall and Mike, any questions for those specific to the product? So if not, if you guys want to stay, you're more than welcome. But if you got life going on around you, by all means, thanks for your time, and certainly the beginning of the conversation, not the end.
Well, thank you guys very much. We really appreciate you giving us this opportunity, and we're very excited to be working with you guys on this project moving forward.
Randall and Mike, thank you very, very much.
And you all enjoy your evening and enjoy your weekend.
All right, so we'll let them jump off, and then we'll pick up the rest of our agenda. So just let me dovetail off of what everyone added. So again, policy will come out to support General Devices and the rollout with dates and training materials and everything else. So we'll let you know well in advance when that's ready, so that everyone can phase this in appropriately.
So we have put a request to the hospitals that was voted on at the REMAC. There's a deadline. The hospitals have to have this up and running, or at least in their ER by the 1st of July of this year. That's so this way, if we have 1 or 2 agencies starting to crawl using this, that's great. But we need to get it up and running. And so we put a hard deadline for the hospitals, because remember, they're funding this. So without them participating, we wouldn't have the funds to start it. So you'll see on the updated or revised policy for this, there's a hard start time. That hard start time is for the hospitals to purchase. For us, there's going to be a very gradual rollout. And towards the end of this meeting tonight, we're going to ask for a couple of agencies to email the region if they're interested in being volunteers to trial the service. So Don, you want to start the agenda slideshow?
Yeah, there was just one other question about EKGs. So just for your awareness, General Devices has been in National Medical Control for years, and by that I mean many years. So it has been utilized in this region, sort of behind the scenes. This is just a continuation on that theory out to the field. So more to come on EKG transmissions, more to come on video conferencing, RMAs, more to come on all of that. But thanks for the questions, guys. And of course, continue to ask. That's why we're here. So let me put up a screen share, and we'll get that done.
Don, you're not using your kid's Chromebook again, are you? Just kidding.
No, those Chromebooks are busy right now playing video games, so it's quiet. All right, you guys see the introductory slide?
Yes.
Yes, it's up, Don.
All right, Dr. Kugler, take it away.
Jeez, thanks. Okay, so again, we introduced ourselves before. If Don, if you can move to the agenda. Next slide. So on the agenda, some of the things that we're going to go over are sort of just regional regular business, and that includes the annual survey for the agency. Again, this is more important than ever because we're starting to use this eBridge tool, and we need to know what providers are in your agency. If you don't tell us, we can't give you a user ID for them, for the eBridge tool, and we don't know what resources you have. We just found out that an agency lost their ambulance and that they have no other ambulance. Using this tool, completing this tool, we'll know that you're not available. And then we'll be able to facilitate your notification of other agencies nearby, maybe activating your mutual aid plan. We're here to help you. We're not here to take over the world. Our job is not to tell you what to do, but really to sort of facilitate regional quality and provision of patient care. You know, the whole goal of this is to make sure that our families and our friends and our loved ones and our colleagues and our neighbors get the best quality out of hospital care that we can provide, that the region can provide. And this is one of those tools, and you guys are essential in that provision of care. We all have skin in this game, and you know, whether it's you work here, you live here, you have family here, or all three, we need to make sure that what's happening is always at the highest quality, the most professional level, and we're bringing that up to that level. So thank you. So with that, one of the things that's also required, in addition to the annual survey, I can't advance your slides, Don. So if you get to the next one, that'd be great. Is the agency medical director forms. So we have this discussion every year. We send out notifications. This is not been going on for 1 year or 2 years or 5 years. This has been going on for many, many years now. Agency leadership or agency medical director forms are due January 31st, 2023 at midnight. February 1st, your agency will be considered to no longer have a medical director. You'll have to be downgraded to BLS. You won't have access to medical control. And the region, the REMSCO, will have to place a medical director in so you can continue operating at the level of care. I don't think your medical director wants that. I don't think your agency manager wants that. I don't think your members want that. I don't think your leadership wants that. But that's the obligation we have because there have been agencies in this region that have recycled names of long retired physicians who, when reached out to, had no knowledge of there being an agency medical director. So this is just a simple verification letter signed by the doctor and signed by the agency leader. It takes 2 seconds to do. It's on the Nassau County website, and you must do it. You know, your level of care is actually given by the state of New York Bureau of EMS. I understand that, but what we could do as a region is we could say we're not going to let you use our medical control because we don't recognize you as an ALS agency without a medical director. As a matter of fact, without a medical director, just to continue on a little bit longer, you really can't have an AED. You can't use albuterol. You can't even use oxygen because it's a medical therapy and you need a doctor to sign off on it. So please, 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 please get those forms in. Because there's also doctors that switch around. REMAC structure and duties. So the next slide, because you can't really see it, is, what does the REMAC do? REMAC is basically responsible for the medical care and oversight of the care and quality of patient care in the region, as opposed to the REMSCO, which is in charge of the operations of the region. That's why when you guys change the order of which you're going to respond, that goes to the REMSCO. But when we credential medical control physicians and we credential providers and we have a regional medical director, that's on the REMAC. So we've divided our duties. That's all set forth in the state public health law. So if you have any questions about it, if you have any concerns about it, all of our duties and tasks are defined for you in Article 30. So the REMAC is all volunteers, all volunteer physicians. You have to be a voting member. In order to be a voting member, you need to be a physician. And we have non-voting members that some of which are actually in this meeting. And everybody's voice is important, and everybody's voice is everybody has a voice at the meeting. They're public meetings. New York State open meeting law says that every meeting has to be videotaped, every meeting has to be in person, and anybody and everybody can come to the meeting. So we want you to come to the meeting, especially if you have a question. Let us know. But it's Robert's rules governs the running of the meetings. So we just like in Congress, the chairman of the committee acknowledges the speaker. They say you have 5 minutes, and then that's it. So that's the way we run it, just because we want to make sure we have proper decorum. So the other thing that the REMAC does is we develop protocols, but we've decided to use the New York State regional ALS protocols. And for those of you that don't know, New York State has now merged the ALS and BLS protocols so that the BLS protocols will reflect what the collaborative protocols look like. And for those of you who operate in both Nassau and Suffolk County just came online with the collaboratives as well. So there's only two ALS protocols in New York State. One is the collaboratives and New York City's. So it's really quite remarkable that we're coming to a New York State level of ALS care. As you can see on the slide, we approve physicians to provide medical control, to provide medical direction, and for regional quality improvement. The New York State regional EMS system is just sort of this crazy map that you see on the left, and REMAC sort of sits in here somewhere. And what we do is we actually report to the CMAC, which reports to the Commissioner of Health, which reports to the governor. So when people are upset with us and they say, well, I'm going to speak to this guy or that guy, you have to make sure you're speaking to the right person, because we report up to the state. We don't report locally. All right, Don, next one. So regional projects. So for those of you who aren't aware, if your agency hasn't been notified, if you haven't been getting Don's weekly messages on his EMS coordinator, I guess, updates, which you really should read. They're very full of information, and sometimes the information changes. We are now an RSI region. It was voted to be an RSI region, I think last year. Dr. David Newbert is aggressively working to build the minimum training requirements for the provider, the minimum standards for an EMS agency, some of which are defined in actual law, and some are defined in EMS policy. Right now, we have 4 EMS agencies that have expressed interest and that meet criteria to become an RSI agency. So if your agency is interested and you meet criteria for that RSI process, please reach out to the REMAC or Dr. Newbert, who's chairing that committee, so we can keep you in the loop as to what we're doing in terms of training, education, certification as an RSI medic. Remember that RSI can only be done by paramedics. It can't be done by AEMTs or EMTCCs. That's a regulatory issue, and it's also a quality of care issue. They're just like certain medications that we use can only be used by paramedics and not EMTCCs. The second thing is the BLS iGel. So there are now 4 agencies in Nassau County that have petitioned the Hudson Valley REMAC to become part of this experimental process where, yeah, thank you for posting that, Dr. Newbert's email. So there are 4 agencies that have requested to become part of this BLS project, and it's using the iGel supraglottic airway. You have to use the iGel, and you have to use all the policies and procedures that the Hudson Valley Experimental Program has set forth, but you have to notify our region first, and then you have to apply to the Hudson Valley REMA or region so that they can give you approval. Without going through all these little hoops, you can't get approved, because remember, this is still experimental. This is not a protocol. You're going outside the scope of practice. If you do this without permission and without your medical director's approval and training, there's a very strict quality control on this, because there's a potential, if you do it wrong, to kill somebody. So we want to make sure that everybody does it right and trains right and keeps the region up to date as to what you're doing. Again, Dr. Newbert, who's the master of all our airway in Nassau County, is also chairing this committee. So if you want to, you can just reach out to him and he'll help you guide your agency through to satisfying the requirements for the BLS iGel. Last thing is Narcan leave behind kits. So multiple health systems, the police department, everybody's leaving these Narcan leave behind kits. They may be used by the patient before you get there. Sometimes patients get 2, 3, 4 doses before you get there. Just make sure that they were administered properly. Your agency may be doing them as a public safety thing. The law has changed to allow Narcan to be dispensed without a prescription per se to a specific individual. It could be given as a public health urgency. Don, help me out with the nomenclature, but so agencies can get these Narcan leave behind kits. And if you have hotspots or patients who are you're frequently called to the bedside for opiate overdoses, please see if you can get these Narcan leave behind kits and give them one. The region is also looking at maybe even doing what they're doing in Albany, which is starting Suboxone therapy. That's not going to be by you guys, but it'll be done by a specially trained physician who's trained in opiate addiction and Suboxone use with telemedicine that, hey, we can use with eBridge. So lots of things changing. All right, Don, I think you're up.
Yeah, it's Chuck. If you want, I'll go next.
Okay, great. Thank you.
Oh, Don, you want to do the board? That'd be great, and then I'll dive in. Go ahead, Don. I'll follow up.
Yeah, so good evening, everyone. Just to really refresh everyone's memory, the intention of tonight was to onboard new EMS leadership as we've changed calendar years. So the diversion board is up. The links are on nassaems.org as everyone brings awareness to this. But as always, if you have any questions, please don't hesitate to reach out. And as you update your new agency leadership, if indeed you're one of the agencies that changed this year, don't hesitate to give them our contact info, as I'm sure that they have questions about EMS. So then let me also do this one. So hospital turnaround times, or wall time, as it's called some places. So this is also a metric we began tracking. It does appear in the weekly EMS coordinators briefing, which again is distributed and then posted on nassaems.org under the EMS coordinators tab. We did have a hospital leadership meeting CEOs and high-level executives with their ERs and everyone else to bring awareness to this, that this is something we're tracking, not as a threat, but as a collaboration. Truly now more than ever, out of hospital and in the hospital are connected at the hip. So we asked them in that introductory meeting that if they are tracking this and do see the same thing we're seeing, that we start seeing how that might be fixed or efforted to be better for both parties on the pre-hospital and the hospital end, and more importantly on the patient end. And if they're not tracking it, we can help them with that, or maybe it's something that they want to start tracking. So most of them were aware of it. They, as everyone else in the country and the state, are feeling the crunch of the healthcare crisis and lack of nursing and throughput in the hospitals. I'll leave you as a reminder, as most of us all know, but it's worth reiterating. Wait times at the ER is not the ER's fault. It's an interconnected healthcare throughput problem, meaning it goes from hospital discharge, which then backs up to the floors, which then backs up into the ER, as the ERs are all holding patients for admission for what traditionally have been unreasonable amounts of time. Those eat up ER beds, leads to lack of beds for us. Couple that with the nursing shortage and everything else going on, and that's why we're where we're at. But if you'd like to be in on the conversation and or have any ideas, please, by all means, don't hesitate to reach out.
So Don, I'm just going to chime in on this real quick.
Yeah, by all means, Don.
So just to let everybody know what we're doing in the background, when we had our we had our hospital administration ED leadership meeting, we informed them of this and that we're tracking it, we're looking at it. We looked at times for Nassau region, we looked at times in New York City, we looked at times nationally. Believe it or not, even though our average time is 30 minutes, the national average is much, much longer. So while we get stuck at the wall, it really stinks to get stuck, because we're all, as volunteers, it's the same for me. You want to get back to what you were doing. You want to get back. You got to get the next call, because there's nobody else to answer the next call. Or even as paid providers, you know that somebody else is asking for your help, and you want to get out and get back to it. Or maybe there's a fire going on, and now you want to get to that. 30 minutes is actually very good nationwide. We're doing very well. Or we could look at internationally, where in Great Britain, the ambulances wait for 24 hours. They don't even bring the patients inside. They just sit in the ambulances lined up outside, parked in a queue. So with that, at the state level, at the last CMAC meeting, there was a great discussion about hospital turnaround time and wall time, and what novel innovations could we use at the state level, the State Department of Health, to sort of get hospitals to improve the EMS turnaround time. So what could they do on their end to get us in and out? In addition to that discussion that was held, and there's another discussion with the SEMSCO, which is the operational side, and the hospital leadership at the state level. I've been meeting locally with hospital administrators here in Nassau County, and I had a great 2-hour meeting with an administrator who actually is a volunteer in the Nassau system as well. He and I brainstormed for a couple of hours, coming up with some ideas, just talking out loud. So this is something that everybody knows about. This is something that everybody's talking about. So please, I know you're frustrated, but I'm just going to, Don, just give me one more second. In the middle of COVID, I penned a letter to everybody saying, we're all tired. It's really true. And even more so now, because we're exhausted. It's not just tired. Everybody we're done, right? We're fed up. There's no more resources to be had. Everybody's gone. The additional resources, the hospital resources, everybody's back to where they came from, because they're dealing with the emergencies in their own neck of the woods. So please be patient, because at the end of the day, we have to remember there's a person that we're caring for. And we want to remember that we're taking care of somebody. This is somebody's loved one. This is maybe our loved one. And we want the best care for them. And if that means you have to stick around for another minute or two, please do so. And make sure you give proper report to the hospital. Just knowing that the hospital may be dealing with 4 or 5 ambulances in a row that you may not know about. So I just wanted to bring that up to your attention. And if you want to discuss this with me offline, I'm always happy to be there for you. We can have a discussion. I can fill you in greater detail as to what's happening. So Don, thank you.
No, thank you. And again, Doc Kugler, Doc Newbert, and all of our medical directors, the high majority of them all working clinically, can really lend and put color on this conversation, from how many patients are being held in the ER for the floors and everything else. Again, not to give any corporate secrets away or point the fingers at any one facility. That's not what it's about. But really just to illustrate the entire progression here. So as this discussion moves forward and EMS continues to go through its adolescent growth phase, tied to this is everything from a reevaluation of, do ambulances, coming in routinely require stretchers, or should they be using urgent cares or ET3 models, all tied in the same conversation, again, invariably interconnected. So really exciting time for EMS. And I'm just happy we fought that war to get away from the Brits, because if I had to wait a few hours, they better be serving me a meal.
You got anything else, Don?
No, go ahead, Chuck.
Okay. All right. As I said earlier, welcome. Thank you for sticking around for this meeting. From the council side, I just wanted to bring up a few points and stuff, just to bring you up to speed on where we are involving the regional council. As most of you that have been in the system for a long time, at least the last 10 years, we made major strides over the past 8 or 9 years, once again getting all of our ALS providers credentialed, getting a new website up, getting all the information and stuff up there on a weekly, if not daily basis on what's going on in the region. Please use it as a resource. Please reach out to us whenever possible, especially with inspections and stuff. If you have questions, we're here to answer them. But that being said, as we said last year, approximately 2 years ago, we lost the program agency. Now, the program agency that we previously had, there was some issues, and once again, we separated. It's contracted through the state, and for the past 2+ years, your council has pretty much been running on a voluntary basis. That being the executive board, as well as certain members within the council assisting us, as well as the REMAC, once again holding meetings and once again handling a majority of that, along with the people up in EAB, which have been supporting us with some of the requirements of the program agency. We have, over the past 6 months, worked with the state to work to reestablish an effective administrative office, program agency, to be able to handle the needs of this region. As you know, this is the 3rd busiest region in the state. We just, once again, put out about 125,000 calls last year. There's things going on daily, hourly, and with that, once again, we need to reestablish that program agency. What I am happy to report is that, once again, we've taken care of all the financial needs, all of the paperwork, except for a few minor issues that we have to tie up with New York State Bureau of EMS, but it looks as though we are going to get that up and running sometime early this year. We've reached out to the county leadership, the administration, and gotten some positive feedback as far as giving some administrative assistance. We're going to sit down with some of the agencies that align with what we do and see if we can come to a consensus on which agency may be able to help us. If that does not work, once again, we will look to an RFP to get a administrative office set up with another agency or another administration throughout the county in order to handle that. So be patient. We are working towards that. The state is working with us to reestablish that, but the day-to-day work is being done on a voluntary basis, along with the assistance of the Emergency Ambulance Bureau and some other entities at times, especially with REMAC and REMSCO, to handle all of that. That being said, we have been meeting the past 9 months. We have 2 separate committees. We established a committee within the REMSCO as well as REMAC, chaired by Dr. Newbert, and on the REMSCO side, Paul Diver from EAB, to set up a committee to once again look at necessary changes to improve our system here in Nassau County. At the same time, myself, Dr. Kugler, and Don Hudson have been sitting along with members of various agencies and various administrations throughout Nassau County the past 9 months, looking at ways to improve the communications, the human resources, and other issues that have stagnated and caused issues throughout the region. With that, we are awaiting the next meeting to hash out where we are, where we're going, how we're going to get there, and be able to, once again, fix some of these problems on the short term and look towards the long-term solutions in order to fix some of these problems. On the communications issue, we understand that there's multiple different PSAPs out there. There's multiple different communication systems, and we're working to get them working hand in hand to be able to improve the response times throughout the region, improve the quality of the care and the response agencies to stop duplications if at all possible. In those situations where, once again, we are short on human resources. We also have been looking to get out to agencies, and we've put it out in the forums and also on the website and stuff to look, if at all possible, once again, look at staffing within your agency, come up with possibilities of, once again, hourly staffing, being able to let us know that you have staffing in-house, that we can improve the response times. Different agencies, once again, have different methods, but once again, looking outside the box, we need to improve in certain areas as far as the staffing, making sure that we can staff 24 hours a day, 7 days a week, 365 days a year, for not only for our agencies, once again, to reduce the burnout, the retention, as well as being able to get people into our services, but also, once again, to handle that for our residents and be able to get an appropriate ambulance in an appropriate time to the appropriate location and get them the help that they need and the care that they need in a professional manner. So we are working hand in hand both with the council and with the county leadership to, once again, try and mediate and trying to fix some of these issues that we know have stagnated our system for a long time. We are moving what I would call, in my 40 years in this business, light speed in many different areas, especially with the communications and also with being able to get the data to drive the decision making, which is coming fast and furious. And once again, as Dr. Kugler said, as Don said, we are here to help you. We are here to answer any questions that you have. We are, once again, here to make this system better for the agencies, the providers, and also for the residents of Nassau County. And that's pretty much where we stand. There are other things that are going on, but we will have future meetings and stuff to update you on those changes as they come. All right, thank you, Don.
All right, Doc Kugler, back to you in the studio.
All right. So, yeah, Chuck, thank you so much. That was a lot of great information, especially about the program agency update. Just remember, guys, that we're all volunteers here on the committee level as well. So when you're demanding something happen quickly, you got to remember we have our primary jobs to take care of as well. So, and with that, I'm going to sneak in a quick thank you to all the REMAC and REMSCO members. You guys, without the volunteer members of the REMAC and REMSCO, we would have nothing. So moving on, equipment restocking. I'm sure everybody's had a problem with this, getting supplies, getting equipment. I just got an email today from an agency saying, we finally got our complement of controlled substances. Guys, believe it or not, even though there's no more shipping container backlogs in the ports, there are still shortages of stuff. Don't wait till you run out to order, because then you're going to be out of compliance And the compliance that we require is not the Nassau County compliance; it's New York State's regulations. So, for example, the narcotics, the controlled substance, it's Nassau County was asked by the state, just like every other region was, to enforce the state's policy on the ALS agencies containing or owning and having the ability to deliver at the side of the patient a controlled substance for both pain and or seizures. So that means you need to have a benzodiazepine and an opioid or ketamine to manage pain. And what we're getting is agencies saying, well, we can't because a vendor ran out, or we can't because whatever excuse. Let us know. There was one agency that got found on a routine state inspection that they had expired for 3 months, and they had no controlled substances. They were all expired, and they didn't let the region know. Had you let us know, we'll help you. We'll put you on a provisional status of ALS, allow you to continue rolling. But the state didn't want to hear from it, so the state dropped them to BLS without without the region having any say. So once the state says something, they usurp our authority. That's it. We got to do what they say. So please let us help you. Keep in touch. Let us know that you're having difficulties getting stuff. Stagger your orders. And Don keeps talking about this in his coordinators report. But if you're having difficulty, let us know. We'll be happy to help you. The second thing is when you go to the hospital and you're asking for equipment or you're asking for supplies, and you said, I need to stock my ambulance. Well, the hospitals aren't there to stock your ambulance. That's actually stealing. You can do a 1-for-1 exchange. That's fair. You can even do, maybe if you use one bag of normal saline and you want to have a spare, ask the nurse, they'll give you another one. But you have to remember, because of shortages, the hospital's short too. So you may not get what you ask for. That's the reason why you have to have a cache of supplies as well, a cache of supplies that are in stock. So don't be put off when the hospital says, I can't give it to you because I don't have it to give you. That's one. Two, don't feel free to go through the ER and just take stuff. So speaking as a little community doc, where our ER gets supplies on Thursday, if you come through Friday night and you take whatever you think you need for the weekend, well, then you've taken what we may need for the weekend, and I'm not going to see somebody to fill my ER until Monday afternoon. So you may screw somebody just because you wanted to put an extra bag of saline in your unit. I'm begging, please only take what you use, and if you're going to take something, ask. Because you may be directed to go to the pharmacy, where the pharmacy can stock you and give you what you need. It's not always a guarantee. So your agencies are expected to maintain a cache of equipment. That's one thing. The second thing is, with regards to stocking, if your agencies are billing and you're billing for the administration of a medication, that means you're billing the patient or the insurance company that you purchased that medication. By going to the ER and getting it for free, you may engage something called the Stark law, which is a kickback law, that you're getting something for free to deliver a patient so that you can get paid. It's very, very dangerous and sticky. So be very careful how you go ahead and restock your units. So always do it with permission. And again, like everything that we do in patient care, it's a team effort. So we want to help you on the ER side, and we want to help the ER on their side, but we can't do it by screwing them out of their equipment and their supplies. We have to work as a team and communicate. Don, was there anything else on the hospital-based versus agency-based supplies that you wanted to touch on?
Just back to particularly the controlled substances. So it's good form to have multiple vendors in your controlled substance policy so that you're not boxed into just one. You can have a primary. I'm just going to throw names out because they're properly used, not because we're allowed to endorse anybody. But so if you have Boundtree as your primary and they're unavailable, and you call EMP and they're unavailable, and you call Henry Schein and they deliver, the patient wins. If you only have one in your policy and that's the only contract you have and they don't have it, but somebody else does, it could be a problem. So multiple controlled substance vendors in your policy that you can then purchase from. And then lastly, good form again to start that ordering process 6 months ahead. You shouldn't be waiting for the month it expires or any closer than that, especially with the delivery chain and supply chain issues. We all know, for better or for worse, this stuff comes generally from outside our country, whether it's on this continent or not. Not within our control, but the best we can do is work around the system we're given. So that's all I got about that. Thank you. And we had a slide on that. So there you go.
Yeah.
Public complaints. Did you want to touch that one? We're getting more and more of them coming through.
Sure. Just remember, when we're talking about a patient care quality issue, then we need to reach out to the REMAC QA/QI committee. That's Dr. John Zazzo is the chairman. You need to send him an email or send the email to me or to the REMSCO, and they'll forward it. These always contain PHI or private health information or personal health information, so you have to be very careful how you transmit this complaint. The second thing is New York State has a form. You could go to the new Bureau of EMS forms site and download a public complaint. If you're engaging that, rather than if it's for a quality issue, you're going to engage the state and they're going to come investigating. So you need to look at where you want the complaint to go and how you want the investigation to roll out, because there's always follow-up from everything, and you may have unintended consequences. So I encourage everybody, if you really think it's something that's reportable, report it. As a matter of fact, there are mandatory reporting things like a death in the ambulance, a motor vehicle collision, an intoxicated provider, equipment failure. These are all mandatory reporting items that are well delineated in New York State public health regulations. And even if there's an equipment failure, you actually have to report it to the FDA as well. So if you need help, once again, reach out to us and we'll be able to help you facilitate that complaint or in the investigation. All right, next slide. This is for you guys. We have a list of policies on our website. The policies are not chiseled into stone. They're a little electronic data bits. And it's policies that are written by the members of the REMAC, both the voting and non-voting members, the members of the REMSCO who ratify the REMAC's policies. We need your input because you guys are boots on the ground. You guys are there day in and day out dealing with communications, patient care, medical control. We need you to tell us how to help you better. We want you to tell us how to help you better. If you don't tell us, we're going to go based on our personal experiences. And yes, we're all boots on the ground people. We're all providing care in the back of an ambulance, responding to emergency calls. But we're using our personal experiences. The more data we have, the better the policies can be. So please, if you don't want to chime up here, I get it. This is a public venue. You want to reach out to us, reach out to Don, reach out to myself or Chuck or Dave Caldor. We're all listening and we want to help you. So please let us know. Okay, ED admin meetings. So you want to talk about that, Don, just to let them know what we've talked about there, the EPCR image trend?
Yeah, so we mentioned that a little bit, but worthy of repeating. So virtually all of the hospitals in the region have been onboarded with Image Trend Viewer. That's their single source platform, single source login to retrieve PCRs. The days of faxing need to be coming to an end. We may not be there just yet, but we certainly are moving in that direction for two reasons. The first is the hospitals are able to import our electronic PCR data in electronic format directly into the patient's in-hospital chart. More so now than ever, they're becoming a continuous one-stop shop for the entirety of patient care, from 911 through EMS, through the ER, up through admission and down through discharge. We will eventually get to a place where there's bidirectional flow in that. So most of you should know by now, there's a tab in your ePCR platform to see what happened to that patient in the hospital, what their admission diagnosis was, what was their discharge diagnosis. So if you ever wondered, hey, that guy we had last week, I wonder how he made out, we're closer now than ever, and you guys play a vital part in that. So that's what Image Trend Viewer is. We already discussed turnaround times.
Yeah, Don, there's one thing that I did forget under the regional. I'll throw it out there while I'm thinking of it. For all the agencies, once again, the different administrations, hospitals, this year's for 2022, the awards forms are out on the website. They will be posted, and they are also on the state website. Please, if you have people, ALS, BLS, educators, the different academies, look at the forms. Once again, please nominate your coworkers and anybody you feel is worthy of, once again, being recognized. We hope to have a type of award ceremony sometime EMS week in May. So please get that out to your agencies as well as the battalions and to other agencies, both paid as well as volunteer.
Thanks, Chuck. That's great. I want to just remind everybody that because all of our providers, even the leaders, there's an opportunity for leadership awards, are working so hard through this pandemic that's never ending. We need to recognize each other as heroic individuals. Sorry, Don and I were just chatting offline about going off script. I'm going to go off script for just a minute. For those of you who have been doing this since before the pandemic and continued through the pandemic and continue now, you're true EMS and healthcare heroes. You're freaking heroes, just like Superman and Superwoman. I can't say enough, because when COVID started, nobody knew what the heck it was. All we knew is people were dropping dead. They were crashing their cars. They had COVID. They were having heart attacks and they had COVID. They were just short of breath and dropping dead in front of us and they had COVID. And we knew there was no cure. We knew there were not enough ventilators. We knew there was no antibodies, no vaccines, nothing. And we continued to provide quality of care to our neighbors, our friends, and our loved ones day in and day out, risking our lives. You guys risked your own lives. You risked getting the disease and bringing it home to your families. And you continue doing it, going into the face of danger instead of running away. Throughout this entirety of the pandemic, I just need to say that you guys are all real heroes. You're my heroes. I admire each and every one of you for everything that you've done these past 4 years, just training up, masking up, taking care of our patients the best that you can with the resources you have. I know we're not at the end of this stupid presentation yet, and I just need to wake you up. I want to say thank you, because you're all really our heroes. You're America's heroes. You know, people don't think that anymore. We were heroes for 5 minutes on TV, but really, in my world and to each other, thank you. You're all real heroes. All right, so the Nassau EMS Modernization Project Committee. Sorry, I had to get back on the I got a text message, get back on the agenda. This is what Dr. Newbert and former Chairman Paul Diver are working on for the REMAC-REMSCO side, and Chief Utero, Chairman Mackey, myself, and Don Hudson are working on the other side. So there's 2 parallel committees. We're working to make EMS better in Nassau County. 3 years ago at the REMSCO and at the REMAC, we ratified a statement that was signed by all the leadership saying, we vow to improve the regional EMS in Nassau County, by whatever it took. We wanted to make sure communications got better, dispatch got better, patient care got better, everything got better. We were tired of hearing ambulances not getting out to patients' homes, which could be our loved ones, which could be for ourselves, while there's 4 ambulances at another scene just sitting around with crews doing nothing. Those ambulances could be used to be deployed to the people who need them. We need to better improve our dispatch. We need to better improve our communications, and we're working so hard. On the political side, they've come up with all sorts of great ideas, but each thing costs money. Each thing takes time. Each thing takes buy-in from all the different constituents. So we're working on it, and we need your help. We need your input. So if you have an idea, you have a suggestion, please give it to us, and we'll bring it back to these committees where there's a political voice. We need your help because we can't keep going the way we're going. So that's all I'm going to say about this modernization project and committee. It's ongoing, but like quality and policy, we need everybody's input. We need everybody's voice.
So I'll jump on that. So just to show you some tangible thing that has come of that. So the county has spent nearly $600,000 on a CAD upgrade for Firecom called Crew Force. You've probably heard of it already. If you haven't, there's much more information coming. But it's an effort to bridge the multiple PSAPs that we have, again, at no cost to any agency. Nobody's going to have to change anything, their CAD vendor or anything else, but it'll be an interconnection between virtually any and every asset we have. Again, we talk about ambulances, but potentially even bigger than that on the county level. So more on that to come, but just to bring that to light here. So I guess it's time to hear from everyone that's stuck with us this far. So anyone have any questions? The chat's open. We're looking at that. You can unmute if you'd like. Questions, ideas, reaching back to 2022, looking forward to 2023. Again, we need ideas. We're open to ideas. And more importantly, we like the collaboration when not all of us are going to be here forever, so time to start indoctrinating some new blood into this too.
You always have to be training your replacement. That's right.
Yeah, your first day is also your last day, so who's next, right?
Right.
So we'll keep moving, but again, if you have anything either today or you know, by all means, our emails are always on, so that's probably the best way to get to us because it can be shared amongst multiple people. So next meetings like this, whether it's just providers or it's specifically to agency leadership or it's specific to medical directors or better yet, maybe everyone at once. How often? What should that look like? What works best for you? We've tried weeknights, we've tried weekend days, and now we've tried weekend nights. So I know there's no one magic recipe given our various backgrounds and demographics of leadership, but this is being recorded to answer one of the previous questions in the chat. It will be posted and distributed. So those of you that are looking for excerpts from it, whether it's GD, eBridge, or anything else, that will be made available. And I'll make sure that it goes out to everybody once it is and where it is and what the link would be. So again, how often? What should it look like? If any of you want to present a specific topic, maybe you've implemented something within your agency that's worked exceptionally well. That could probably help many other agencies that are probably struggling with the same problem. Maybe they haven't tried what you tried. Maybe it didn't work out for them. Maybe they just didn't even think of it. So we're certainly stronger together than apart. So there's our contact info. Most of you have it. remsco@nasaems.org is probably the best place to start, as that's monitored by REMSCO, REMAC, program agency. It's monitored by multiple different people. So that's the one-stop shop, and then we can parse it out to there. So as Doc Kugler is saying, if you have, we'll use the iGel project. So you're like, hey, I want to do this iGel thing. Who do I talk to? So send that into REMSCO, and we'll send it out to REMAC awareness, meaning Dr. Kugler and REMAC leadership, and then over to Doc Newbert, who's taking the lead on that. But we'd like multiple eyes on that. Again, it's a collaborative effort in every way, shape, and form. We have a phenomenal, energetic, dedicated group of people right now that I don't know that this region has ever seen anything like before. So thank you to my peers, my partners, my mentors.
So
Doc.
I did see a text message. Love this forum. Thank you. Lisa, thank you so much for that compliment. Yes, I agree. Saturday night is really not the most uh, opportune time, especially for people who want to engage in a social life. But we had to work around clinical availability, family availability, other obligations from on our side, and um, this was a date that seemed to work out for us, and we wanted to do it in a timely fashion. We could have said, "Oh, let's wait till March," but that wouldn't be fair to you, all the other EMS leaders in the region. We needed to get this information out, and yes, moving forward, we could do it in a more reasonable fashion, sort of like at midnight on a Wednesday, right? So when everybody's sleeping. I'm just kidding, but we'll
We
figure
don't,
something
hold
out.
on. We don't discriminate against midnight workers. That's a
Hey,
uncapped demographic, so don't joke.
no, hey, what do you think I was doing Friday? I was at work at midnight, so um, I was ripping on myself. Let's see, we got a couple more. Any chance we can have an open question time for the public? Uh, I don't know what that means.
I guess the
Uh,
public means EMS providers, or if you're on this call, you can unmute and let us have it. So please do
yeah,
so. We do this. You don't want to hear from us. We want to hear from you. So if you can't unmute, raise your hand. If you can't raise your hand, type it in the chat because that's where you already put it so we can see you.
right. So just quick, somebody else asked ACS trauma protocol / AEMT intubation. Okay, two questions. So the ACS trauma protocol, the CDC has modified the 4 boxes for trauma. I was going to say the health system, switching hats. The State Department of Health is integrating that into the policies, procedures, and protocols. So when it gets integrated, that's when we use it. Um, we have to follow the protocols. So when New York State puts it into their BLS protocols, that's when it becomes our protocol. With regards to AEMT intubation, New York State has removed AEMT intubation because it's following the national standard of education and didactics and skills set forth for each level of provider. So the EMT doesn't do iGel anywhere in the country. So that's why the EMT BLS iGel project is a scope of practice that is experimental, and we have all these regulations and hoops to go through. Intubation was removed from the AEMT skill set because it is not on a par with the national standard, a national curriculum. And so the only level that can intubate in our region is the EMTCC and the paramedic level of provider. As our EMTCCs begin to sunset and no longer recredential or upgrade to paramedic, it will just be the paramedics able to intubate. So I hope that answers that question.
And
Keep going,
let me
guys.
just jump in on that, Doc.
Yeah,
And
yeah.
just before anyone says it or comes up anywhere else, AEMTs were never allowed to intubate in Nassau, even though it wasn't collaborative. One of the regional modifications to that was AEMTs were not allowed to intubate. So it's not a huge impact. Please don't lose your mind. It was added for upstate regions that use AEMTs in tactical environments and whatnot, and even they don't have a problem with it. So as we go more towards national level stuff, it really just makes sense.
Yeah, thank you, Don, for clarifying.
So B, whoever that is, that's the any chance we can have an open question time for the public. Speak now or forever hold your peace, or speak now, I should say, or forever send an email.
So if you're referring to whoever that B person is, if you're referring to open chance to ask questions, well, that's what the REMAC and the REMSCO meetings are for. Uh, they are open meetings as required by New York State law. And if you have a question, you want to address each of those groups, the meetings are posted online on the Nassau EMS website. They are held monthly. The first Wednesday of every month is either a REMAC or a REMSCO meeting. And the locations are also posted. So if you want to have a voice at a public meeting and be heard, you're welcome to come and join us. Let me see why you can't unmute. Yeah, I can't unmute the person either. Don, can you? That person B?
So lowercase b, I don't see them even in the attendee list. So
Yeah, just, Dave, just along that, as you just said, the next REMSCO, meeting will be held, I believe it's Wednesday, March 1st at 2:00. It will be held at the, Homeland Security Center over at the Morelli Center on, Grumman Road West in Bethpage. Once again, as Don said, the more people that show up, we need fresh blood. We need fresh ideas. We need people to come to these meetings that are going to replace us in the future. And no better way to learn about what's going on throughout the county than to show up at a REMSCO or a REMAC meeting and get that information.
Yes, and the next REMAC meeting is Wednesday, February 1st. So the question, can you send the questions in? Yes, of course. You can type a question into the chat box now, and we can try and answer it for you. Or you could send us a more thoughtful and laid out question and by email, and we can address it. We could address it to you directly, or we could bring it up at our next quarterly meeting. So that's the other thing. We don't know if you want us to meet quarterly, semi-annually, annually. If you're sick of this, if you said I've had enough, you know, I want to go back on my way. So your input into this is very important because it's your EMS system. You guys are the leaders, the boots on the ground leaders for EMS, for all the 80 agencies in Nassau County, for the over 150,000 calls and the 1.5 million people that we protect. You know, we have enough people. We do enough calls like a small country. Okay, so you guys are really doing incredible work, and we need your input. We need your guidance. It can't just be 20 doctors and what is it, 25 constituents in the REMSCO. Okay, so thank you. Very informative. We'll send questions prior to the next meeting. Fantastic, and hopefully we'll get to them.
all right, good stuff then.
Yeah. Sorry, my Apple Watch keeps binging. It's really
You're
annoying.
binging away there. It's probably your heart rate.
No, it's every time I get a text message on the Teams, it's comes on my watch. It's kind of cool, but annoying at the same time.
All right, everyone. I don't have anything else. I want to thank Dr. Kugler and Chuck for their time. Again, they don't get paid for this at all. So sort of a thankless job and certainly not very profitable, but thank you. We'd be nowhere without them.
Well, thanks. I appreciate the acknowledgement. And Chuck, thank you as well. And Don.
And Dave Caldor and our new Secretary Treasurer of REMSCO, Tom Devaney. So
yes,
more to come. Emails are on. Please let us know what you need, and Happy New Year, everybody.
Yeah, thank you everybody for attending. Really do appreciate it.